So we need to be able to understand the emergency and first aid treatment for burns. Again, there's a nice table in your textbook about that. You know, it starts with stopping the burning or extinguishing the flames. We learned this way back when in elementary school when we had to practice stop, dropping, and rolling. But also, if it's a thermal flame, that's obviously what you're going to do if your clothes were on fire or something. But also, we want to point out that stopping the burning is also removing any jewelry or other metal objects that are transmitting that burn. So remove any smoldering clothes, chemical. It depends on if it's a dry or liquid, but we'll brush it off if it's dry, and then we'll have those flush stations if it's a chemical burn, if you're working in an occupational setting with chemicals. Electrical, stopping the burn would be stopping the current. So if it is actual electrical worker and they can stop the current to that line. And then radiation, of course, is removing the source and getting out of the radiation therapy or the radiation sunshine that is causing the burn. ABCs then will be next in line, and obviously airway, breathing, circulation. So once we have established safety and gotten rid of the burning, and we're not going to go in and try to help someone if the current is not off, obviously, or we're going to be electrocuted as well. But then we will basically start with our ABCs and CPR if needed. So airway patency, breathing, of course, we're doing a quick glance at any of those airway, respiratory type obvious signs and symptoms that we might be able to visibly see and or hear in their breathing pattern, assessing for the wheezes, the stridor, etc. And they're definitely going to have a prophylactic endotracheal tube, so we're going to get those patients tubed, because we know that if they have an open airway now, that it's very likely that that edema is going to increase, and they will likely have a closed airway, and we don't want to wait for a respiratory rest. We want to prophylactically prevent that. Electrical burns, there'll be a high probability that they would be in cardiac arrest or a ventricular fibrillation. So once we have safety of that burn site, then we'll be going into our code blue and our defibrillation. As far as flushing the wound or cooling the burn, that comes in next, and that is just cool water. So if you've ever burned yourself, just even with a curling iron, or while you're cooking, like on a hot pan or steam injury, hopefully you've ran it under cool water for a few 30 seconds, 60 seconds. I mean, we want to make sure we cool that burn down. We don't want to apply ice, because that causes too much. It causes vasoconstriction and decreases blood flow to that area. So typically we wouldn't tell people to apply ice, but just cool water or cool compresses, excuse me. And we don't ever want to apply ointment or salves or to it. So while there's lots of wives' tales about what to put on burn injuries, if somebody's calling and we're doing triaging, we would tell them to stop the burns, make sure the ABCs are intact, and then basically flush the burn, cool the burn, cover it, and then obviously get to be seen or call the ambulance, obviously, if there's a more severe problem with the ABCs. Covering the wound, this is going to accomplish three different very important things. We're going to conserve heat by covering it. We're allowing less heat to be lost through that open skin area. We're also going to minimize or decrease the amount of bacterial contamination. It's already been exposed, so there's already been risk of bacterial contamination, but we don't want to have more of that. And then also decreases the pain. Because air is coming across and in contact with those injured surfaces and all the nerve endings that are there, that can cause a lot of pain. So we're keeping some of that heat in, we're decreasing the bacterial contamination, and we are decreasing pain by covering. So just covering with a clean sheet, whatever we might have that is clean. When they come to the emergency room or in the ambulance, they'll have taken all of their clothing off and be covered with a clean sheet. So with this practice problem, what should the nurse advise the mother to do? The answer is 3, apply cool water to the burned area. Now we're going to start talking about all the phases of burn injury, which you will need to know what types of physiological changes are you expecting during each of these phases, but then also what are your nursing priorities for the phases. So the very first phase of the burn injury is emergent or immediate resuscitative phase. So it has a couple different names to it. I'm not sure which one you will see, but emergent immediate resuscitative phase. This happens from the onset of the burn injury to completion of fluid resuscitation. It is approximately the first 24 to 48 hours. Now, priorities in this phase are things that we've already talked about, that emergency first aid management, which we talked about extinguishing the flames, stopping the burning, making sure the ABCs were intact, cooling or flushing the burn injury, and covering the wound. So just what we talked about. Other priorities is prevention of shock. Remember, if you think back to the physiological changes that are going to be happening, there is the hypovolemia, loss of fluid through the and proteins through that increased capillary permeability, and then also the third spacing. So prevention of shock and hypovolemia, obviously airway breathing, prevention of respiratory distress. They will need 100% oxygen. They will have an endotracheal tube and be mechanically ventilated. We will also at this point in time be doing a quick triage of other treatment injuries. Do they have other fractures? Do they have inhalation injury? Because we have other things that we have to deal with besides the burn injury if that is the case. And then there will be an initial wound assessment and initial care, which is basically just covering the wound and doing that estimation of total body surface area, either using the Paul method or the rule of nines. So this slide goes through the nitty-gritty fluid and electrolyte changes again that you'll need to know for each of the phases. So in that first 24 to 48 hours, the emergent immediate resuscitative phase, we can expect the burn shock, the hypovolemia, that decreased blood volume, again as plasma leaks through the damaged capillaries, as the protein is lost through that area, and fluid. We also expect that third space fluid shifting, or the burn edema. So burn shock, burn edema. With the decreased blood volume and decreased cardiac output, you'll see as a consequence of that the decreased urinary output, because we have the activation of the sympathetic nervous system that then reduces blood flow to the kidneys and will reduce the total glomerular filtration rate. So we will expect decreased urine output as we would with anybody that is in shock. Now, potassium excess we talked about. This is because of the tissue destruction. Remember, potassium normally lives inside the cell. So when we have cell lysis with the cell destruction, that potassium leaves that cell that obviously is dead, and that basically is broken, and that puts more potassium in the blood. Sodium deficit, a couple different reasons for that. Sodium trying to go back into the cell because of the potassium coming out, but also we have a lot of sodium that gets trapped in the edema with that third space fluid shifting. Metabolic acidosis is a possibility. Again, I want you to try to remember our little trick with the potassium and pH having inverse relationship. If the potassium is elevated, which it will be initially, we will expect to see a lowered pH. So metabolic acidosis, which would be a pH of less than 7.35 and a bicarb of less than 22, 21, basically a bicarb that is low, right, and a pH that is low. Metabolic equal, low pH, low bicarbonate would be what we would expect to see if somebody has this metabolic acidosis going on. And then with the low blood volume, remember we have high blood osmolality or high concentration, so we're going to have a concentrated, kind of a falsely concentrated hemoglobin and hematocrit. Another thing you could add on this slide is just that they're going to be checking the BUN and creatinine. We need to know how the kidneys are functioning during this very important phase. This is the phase that we need to treat so that we don't go into a more severely complicated or irreversible condition. So what are we doing for patients in that immediate resuscitative phase? Obviously, we're managing the airway, breathing, and circulation. That's our main priority, that we have stabilized respiratory, that we have an open airway, that we have an endotracheal tube, that they're getting ventilated and having 100% oxygen. We're going to remove all that clothing, jewelry, metal objects, contacts. That's another one. And we may or may not know if they have contacts in, but if we can get that from any family members or friends, we would want to take that. Otherwise, those are continuing to burn. on the eyeball, so we want those out. We're going to validate anything quickly from the EMS as far as the burn scene or family members that are present. Do we have a cervical spine injury, any other fractures, and or do we have inhalation injury? Of course, we're going to do that assessment of total body surface area and burn depth. We want to kind of know how much total body surface area we're dealing with, and do we think that we have first degree, second degree, or third degree burns. This doesn't have to be exact by any means, but it puts them into that category of major burn injury right away, and there's a slide on that major burn injury so that we understand if we're going to be most likely dealing with systemic complications, or if it's a smaller first degree total body surface area, we're probably not going to have all these bad, systemic problems. So that's why that becomes important. The clean technique when assessing the burn, covering them with the sheet, obviously that's all, basic, first aid treatment that we already talked about. Now they're going to need large bore IVs, 2 of them preferably. So when we say large bore, that's going to be 14s, that's going to be 16s or 18s. If the arms aren't burned, we have the arms available. If they have severe burns of both arms and we don't have, areas to start IVs there, they could use, put a central venous access device in the chest, do a subclavian or a jugular, or they can use the femoral. So it depends on what areas are burned, where we're going to have access to IV sites. As far as the fluid resuscitation, we'll be going through but fluid resuscitation in treating the burn shock and the hypovolemia is super, super high priority, kind of right after that airway breathing circulation for this phase of care. They're going to need an indwelling catheter in for acrid I&O. We're going to be doing pain management with IV narcotics. If it's a third degree and they don't have pain, of course, they're not going to need that, but just make sure that we're very careful of IV narcotics because they're in shock, so their systolic blood pressure, is likely or maybe less than 90 systolic. So we have to be very cautious of administering meds that are going to further lower the blood pressure and cause that vasodilation like IV narcotics would. So checking for that systolic blood pressure that we have a greater than 90 would be important there, and respiratory rates, and level of sedation, things that we talk about with IV narcotics for other types of patients. Of course, the patient's going to be NPO. They probably will have an NG tube inserted to prevent Curling's ulcer and paralytic ileus. We need to keep pulling out that acid that's still going to be produced during, even for somebody who's not eating. They probably will need an IV H2 histamine blocker, a proton pump inhibitor, so either the DINEs, the H2 blockers, or the ZOLE meds that are the proton pump inhibitors. We need to reduce that hydrochloric acid because during a stress response, we know that hydrochloric acid will be increased. Of course, there's the obvious family and psychological needs and care, having somebody, a nurse separate just with the family, having pastoral care or somebody else be there while we were stabilizing and getting their loved ones shipped off to the burn unit, or maybe they're getting a phone call and they're basically en route to the next level of care to meet their loved ones. So it can be a very, very stressful situation for all. Complications then that could happen in this emergent immediate resuscitative phase, again that first 24 to 48 hours is the obvious. So the shock, of course, they're going to be hypovolemic and going into shock. We've gone through those phases, so we want to make sure that we are treating them during the compensatory phase. So there's compensatory phase is the first stage, and then there's the progressive stage of shock, and then there's the irreversible, if we remember back to that. So we need to get them treated and get them successfully fluid resuscitated during that initial first or second phases of shock so that we don't go to the irreversible where we're going to have multi-organ shutdown and the patient is not going to survive the shock and the burn injury. So arrhythmias are possible. I failed to say that they will be on a telemetry monitor. The leads will be applied, of course, because we're expecting hyperkalemia. We're watching for other dysrhythmias, but looking for those peaked T waves and watching for any of those complications of the hyperkalemia. Also, under the circulatory area, making sure if there is a circumferential burn or so much constriction and swelling in the internal compartments or by thick eschar or dead tissue that's cutting off the blood flow to that area, we need to be watching for decreased tissue perfusion. Pulses, drip refill, temperature, color, all of those things. Respiratory-wise, of course, laryngeal edema, if they have that hoarse quality of the voice, that could be the glottis swelling, the larynx, laryngeal area, and either way, that could mean that there is even more constriction happening and could be a precursor to the airway actually closing completely. And then we talked about the carbon monoxide poisoning, where that carbon monoxide hooks onto the hemoglobin molecule instead of the oxygen, and therefore they become very, very hypoxic. Renal failure is a great possibility, especially if we don't get them fluid resuscitated quickly, and so they can end up with decreased, well, they will end up with decreased GFR, but if we can't repair the cardiac output and the perfusion to the kidneys, they could go into a progressive stage of their renal failure. So again, I encourage you to think, how would we treat these complications? How do we treat hyperkalemia? How do we treat shock? What position do we put them in for shock? We're going to have them in that Trendelenburg position. We're going to get them fluids. Do we understand how to do respiratory resuscitation if needed? So just be thinking about what are all the signs and symptoms of these complications, and what is it the nurse is going to do to help facilitate prevention or early treatment of these problems. So priority nursing diagnoses for this initial immediate resuscitative phase, we're going to be looking at your fluid volume deficit, of course, and the hypovolemia. Certainly very high likelihood of impaired gas exchange and ineffective breathing patterns, and for sure will be that if they have inhalation injury. But even if they don't have inhalation injury, certainly a possibility. They're at risk for infection in this phase. They'll be at risk for infection in the next phase of care as well. But they've had exposed areas to the open, that have been open and had the chance of bacterial contamination. Impaired tissue perfusion, that goes along with the low blood volume and the low cardiac output. Certainly anxiety, pain if it's a first or second degree burn. Impaired thermal regulation, again, remember initially they are going to be hypothermic. And then, of course, the obvious is impaired skin integrity. So if you were putting this in the order of priority, at least the first four, impaired gas exchange, number one, ineffective breathing pattern, right, number two, that's airway breathing. Impaired tissue perfusion is our circulation. Fluid volume deficit, hypovolemia, that's our circulation. So those are definitely going to be the top four, I would say probably in that order. Then I guess 5, you would go to thermoregulation, because that's technically a circulation type thing as well. And then probably on to impaired skin integrity. So hopefully you're getting very skilled at looking at these diagnoses and understanding what the priorities are. And also in your studying, you could stop at this slide and say, what are my actions and my priority nursing interventions for impaired gas exchange and ineffective breathing pattern? What am I going to do for that patient? And those are good ways to study the application part of things. So this is a sample problem on the Parkland-Baxter formula for fluid resuscitation, which is standard for major burn injuries. So they're going to have this formulation as calculated in this problem. You would get all the information you need to do the dosage calculation. So I'd like you to do that now, and then on the next slide we will go through the answer. So this would be how you would calculate this. You would initially have to convert the kilogram, do the kilogram and put that in the formulation and percent body surface area. So we're basically just plugging in everything that was given to us, 4 milliliters times the 68 kilograms times the 50, which was the total percentage of body surface area. And then we get our 13,600. And the formula says that we have to get half of that in the first 8 hours, which is how we end up with our 6,800 milliliters. And then we take it divided by 8 hours to basically get our mils per hour. The next phase of the burn injury is the acute intermediate phase. So this is from the start of diuresis, approximately at 48 hours, but whenever we start having diuresis, that is the onset of this second stage acute intermediate phase. So that can happen sooner than 48 hours. This is a good sign. We're happy to see fluid resuscitation that is working. So this is called the fluid remobilization phase, and it can last weeks to months, but initially it's again, it's starting kind of right after that hypovolemic phase and that very first phase that we just got done talking about, the emergent immediate resuscitative phase. This is following that phase. Again, as soon as we have fluids that are working and kidneys that are starting to diurese, we're happy. We know that kidneys are working. We know that the patient is responding to the fluid resuscitation. So acute intermediate is easily identified because it's identified by the start of increase of urine output. So fluid and electrolyte changes, we're looking at the increased urine output. Now we're looking at hemodilution. So we have fluid that's re-entering the intravascular compartment. So we're looking at more of a risk of fluid volume excess. We also, with the fluid resuscitation, we've just given a lot of fluids and fluid challenges. So also they might have excess fluid that way, and we'll be diluting down the sodium. So the sodium will still be hyponatremia. It's just that it's a dilutional hyponatremia. Now we're going to be looking for the opposite of the potassium. So initially it was elevated with the potassium leaving the cell and cell lysis. Now we're into the fluid remobilization and we're having a lot of diuresis. So we're losing a lot of urine and losing a lot of potassium in that urine. So now we're going to be watching for hypokalemia in this phase of burn care. And then the thermal regulation is going to flip also. So initially we were hypothermic, and now we are going into the post-burn hypermetabolic, hypercatabolic state. So we are going to expect an elevated temperature, sometimes for up to several weeks post-burn. And if they have any explosive burn injury, their temperature is way elevated and their chance of survival is really low. But again, increased urine output being the main fluid and electrolyte marker of this. With that increased urine, we're expecting diuresis of potassium, so a lower potassium, and then we're also watching for that elevated temperature. Now in this phase of care, we are certainly continuing to focus on making sure that airway, breathing, and circulation is managed and the fluid and electrolyte changes, but most of the time airway obstruction caused by upper airway edema, is kind of that first 48 hours. So hopefully we're kind of getting through the risk of the airway obstruction, occlusion, etc., and seeing more of that stabilizing, but we're still definitely paying attention to all of that. So as mentioned on the last slide, continuation of the cardiac and pulmonary functions, continued monitoring of the airway, breathing, and circulation. In this, we've given fluid replacement. They've had isotonic solutions in the first 24 hours like lactated ringers or 0.9% sodium chloride. Now in this acute phase, they might have continued fluid flushes depending on kidney function and how much urine output is coming, but we would definitely expect to see a switch to a hypertonic solution that is going to pull fluid from that interstitial, all of that third space fluid that has shifted, and get it back into the blood vessel. So a hypertonic solution will be added here at some point in this phase. And then also, hopefully you can imagine where a colloid such as albumin infusions will be very, very critical in a post-burn patient. So those are also hypertonic solutions, but then they're also providing that protein and helping to maintain the osmotic pressure to keep the volume in the blood vessel. And also, obvious reasons, replacing protein for healing and skin repair, etc. Pain management will continue. Now we're, kind of through that shock phase, so it's more, the patient's more stable, so we're able to not worry so much about cardiovascular collapse and dropping blood pressure further and respiratory rate, etc. We're still going to always assess level of consciousness, level of sedation, their respiratory rate and effort, and the blood pressure before giving any IV narcotics, but I know a lot of the times with the major burn injuries they use IV fentanyl or could use IV morphine or Dilaudid. Burn pain has a long duration and just a much higher intensity than other types of pain, so we are definitely managing burn pain as best as we can. They also, if you have a third-degree burn and there's no pain initially, we said with third-degree burns because all of the nerve endings in the dermis have been destroyed, but keep in mind that the pain all around that burn injury, there's pain there. There's nerve endings that haven't been burned there, so they do have kind of that that burn pain that is around the borders of the burned area. And then the delayed pain we will be expecting 2 to 3 months later with the nerve regeneration. And then prevention of complications, so assessing CSM, circulation, sensation, and motion. And again, this has to do with all of the pulse checks and the temperature and the color, and do they have movement, etc. So especially we want to be cued into any of those circumferential burns as far as the onset of compartment syndrome, that we would check for tissue perfusion very diligently. And then wound care is a big part of this management of the acute phase, and we'll be going through that here on the next slide. So wound care priorities involve debridement goals, and what we really want to happen with debridement is we want to remove the tissue that's contaminated with bacteria. We want to remove any of the devitalized tissue or burn eschar. So we need to remove any of the dead non-viable tissue and any of the tissue that is contaminated with bacteria to hopefully prevent sepsis. And then we also want to keep that that area covered to conserve temperature. So that's the importance of the dressing part of it. So dressing changes, they will, if you're working on a burn unit, you will have full separated like isolation gowns that you will be putting on over your uniforms, and separate gowns and gloves and masks that you're only using in a one-time into that room. Strict aseptic technique with any dressing changes, and no cross-contamination as far as assignments with ID patients or infectious disease patients. So anybody with a burn injury would be considered an ID patient, and possibility of having an infectious disease or contaminated, and we don't want to spread that to other patients. Hydrotherapy is a very important therapy that we will have our patients do. They have shower carts, they have total immersions, basically 20 to 30 minutes where they're having all of this. The shower carts and the total immersions are helping with the cleansing of that burn area, but then also a big part of the burn therapy is doing range of motion. So we know that we have improved range of motion in water. They do this a lot for like rheumatic type musculoskeletal diseases as well, the benefits of like water aerobics, etc. with that. So it's kind of the same idea where we could help prevent contractures and really help on range of motion during that time period. And escharotomy hopefully isn't going to be needed, but is a possibility if they're having complication of that compartment syndrome where they need to release that circumferential burn eschar in order to improve tissue perfusion. And then wound grafting, so you do autografts, which is your own skin grafting, in which case you'll have both the graft site of where you took the graft from, but then also the burn injury. So we'll be having to look at a couple different areas for watching for signs of infection. Or we do use a lot of synthetic grafts, which you'll see a picture of here in a minute. Other priorities that occur during the management of that acute phase or that second phase of burn injury is positioning. So watching for contractures and the range of motion, making sure that we're changing positions every 1 to 2 hours, and during any of the water therapy, obviously OT will be in, PT will be involved also for range of motion exercises. Diet, they are in a hypermetabolic state, and this acute phase can be a very long period of time, and so nutrition becomes very, very important. They have, with that hypermetabolic state, they require very significant large amounts of calories per day, 5,000 calories being an average, can be more on that. They need a lot of protein for wound healing, very high probability that they will need total parenteral nutrition or enteral feedings in order to meet all of their nutrition requirements. Emotional support, of course, during this acute phase is super important as well. We need to understand that they have gone through a lot. They survived a major burn injury or trauma, and now they're getting into that very real onset of what's going on. And remember, this acute intermediate phase is a long period. It can last up to months. It's the start of the diuresis when our urine picks up, but it lasts until closure of the burn wound. So it's a very long period of time spent in this part of the phase, because it goes all the way until the closure of the wound. So emotional support, angry, depression, anxiety, they may have regression, they may go back to earlier childhood type behaviors. Again, if it was a child that's potty trained, maybe now they're having bedwetting. Certainly PTSD related to the accident, the injury, the actual fire, or maybe it was a motor vehicle crash that they had the burn injury from. It's not just a house fire or something. So again, all of those things that we need to be concerned about with the patient and address. Of course, we're including them, family-centered care. The whole family's involved. The burn centers, if they don't live close to the metro in our area, they're a long ways away from their loved ones, and maybe a mom or a dad has to travel and be down in the cities while the other one is kind of like a single parent care provider, or maybe you are the only care provider and now you have a child at the burn injury or burn center, and then you have other children at home. So as you can imagine, a lot of financial stress, job, family, and you name it. Complications that can occur during the acute phase. Now we're looking more of the long-term complications. So infection is the main complication that happens during this acute phase, and they have a high risk of infection all the way till the completion of that burn wound being closed and even beyond. So we know that this is a very big problem, and even if they've survived that first stage, we can still have patients die from sepsis because of a severe infection of that burned area. Compartment syndrome, of course, is a big part of a potential complication as well, especially if they have circumferential burns. And it's not just circumferential of the extremities. Let me explain that if they have it around both the anterior and posterior chest, for example, that is causing constriction of the chest. That impacts breathing and the ability to expand the lungs, etc. So it's not just extremities that we're concerned about in checking cap refill, etc. It also can be breathing patterns if it's of the upper torso. Contractures, again, the importance of prevention for that is going to be range of motion. The most common contracture complication is a flexion contracture, so watching for positioning and making sure that we don't have that flexion that is occurring. And contractures can run 1 year or even after a year, so some of these things are things that we're dealing with for a whole long time that we have to help them with. They might have special braces to wear, etc. And then GI complications that occur during this phase, paralytic ileus, where we have that reduction in peristalsis, Curling's ulcer, which is that stress ulcer. Hopefully we can prevent some of these things from NG placement and anti-ulcer medications. And then stress diabetes, that just means that we're going to have hyperglycemia and increased blood sugar as a response to the catecholamine release. So even if they don't have diabetes, they might have a stress-induced diabetes because of the burn injury. This picture is nice, showing the compartment syndrome with the fasciotomy that may be needed. It's showing you that normal compartment, and then it's showing you where all of that swelling of the muscles causes compression of the nerves and the blood vessels, thus reducing that blood tissue perfusion. And then also it's showing you that most common is the flexion contracture, so you can see how the hand is flexing together, and so we need to keep extension and make sure that we don't end up with that hand that is stayed in that position. So hopefully as you're studying, you can see there are very different priorities and things that are happening during this second phase, this acute phase of the burn injury, and you can see that we would have very different nursing diagnoses and priorities. So now instead of fluid volume deficit, because that's what we were concerned about in the first phase, we're actually looking for fluid volume excess. We are definitely much more concerned with impaired skin integrity and the wound care and the risk for infection, continued pain management. One thing that I did fail to mention under the pain management or wound care, which of course is super important, is that we need to make sure we're medicating them prior to wound care. care. So they need to have like an IV narcotic 30 minutes, or if it's an oral 60 minutes before they're going to do wound care, because this debriding, this hydrotherapy and bath therapy that includes some debriding at the same time is not going to be comfortable. So we need to make sure to prepare them for that. Ultra nutrition, less than body requirements. Again, they go into that hypermetabolic state. They require TPN or enteral feedings. Hyperthermia, they have an increased metabolism and increased temperature during this time phase as well. Impaired physical mobility, again, all of the movement, the pain with the movement, the stretching of all of those areas, and then of course trying to prevent the contractures. And then a huge portion of this phase is getting into more of the disturbed body image, the family processes, having to look at themselves in the mirror, having to actually see what the extent of the burn injury is very trying and very traumatic for patients and their families. This is showing you a synthetic wound graft. You can kind of see where that sleeve comes up over the top of the leg. You can see that thin transparency of it. Again, purpose of a graft is to reduce the risk of infection because we're keeping it covered. We also are preventing further loss of protein and other fluid and electrolyte losses through that area of the lost skin, and then minimizing heat loss through evaporation. So all three of those things you can kind of imagine are taking place with this wound coverage. And then the wound graft, it has ingredients that are going to help to formulate the repair of the epidermis and dermal, and it does so over an extended period of time, but can be very successful. This is showing you that, autografts, which is our own skin tissue, isn't necessarily always better. The autografts in this picture, you can see where there's actually better grafting of how it's going to look afterwards, even with the synthetic product that's sold out there. So again, depending on the patient, the situation, the doctor preference, they'll do grafting of some type, whether it's their own or a synthetic material. So the last phase of care as far as burn injury is the rehabilitation phase. So this starts from wound closure, because that's when the acute phase ended. So wound closure to whenever the patient returns to their highest level of health restoration. So again, the rehab basically is, again, the length of time can vary considerably, but this is where we're mainly focused our priorities on psychosocial counseling, that continuation of body image, the continuation of getting back on their feet if they've had a lot of lost off-time work, family that haven't been getting paid, or insurance issues. I mean, there's all sorts of those things that now they're dealing with. Hopefully support groups for both the patient and the family. Continuation, because even a year post-burn, the chance of immobility or contractures or further scar formation and keloids. Keloids are those heaping up of the scar tissue, so they form kind of that lumped area. So we want to prevent any of that to have the best look of what that's going to be afterwards. And then any other functional or cosmetic reconstructive surgeries may be possible. They may also have physical or occupational rehabilitation. They may have more different job training, to maybe they're not able to return to their line of work. All of those things could be happening during the rehabilitation phase. So complications during the rehabilitation phase, keloids is the hypertrophied scar tissue. This is where you have an abnormal amount of collagen in the dermis and subq that kind of heaps up. So you can see across the sternum there where that is definitely clearly heaped up, and you can see on the feet. So I just tried to show a few really obvious pictures. Doesn't necessarily have to be that large of a heap, but anything where the scar tissue isn't flat, patients don't like. They don't like how it feels, and certainly don't like how it looks, so we want to try to prevent that scar tissue from forming. So that's where the Job's garments come in, and you'll see a picture here on the next slide where that will help with compression and help to lay everything flat. So there's certain types of dressings and then certain types of garments that they wear that will help with that. Contractures, again, they need to make sure that they're continuing with their physical therapy. The burned wound tissue shortens, and so you need an opposing force to kind of keep that from flexing. So there's splints, traction, range of motion, occupational therapy to help with that. And then failure to heal. So just because they've healed the wound and the wound is closed, they're not out of the woods. They still might have a very low albumin, and we need to keep working on nutrition to make sure that their healing is the best it can be. Now, as far as going back to the keloid formation, one thing that I wanted to mention is that there are certain body areas that are more prone to keloid or scar tissue formation. The mid-sternum, the back, shoulders, deltoid. So mid-sternum, back, shoulders, and deltoid are very common areas for keloid formation. And then ethnicities, you know, basically all ethnicities besides Caucasian, African American, Mediterranean, Indian, Hispanic, Asian, all of those have a higher incidence of keloid formation, but there are plenty of Caucasians that form scar tissue very well also. But I'm just saying statistically, those are some points of interest that you might be interested in. So management and prevention of complications, we've talked about the physical therapy, the range of motion, the Job's garments you can see in this picture. They do need to wear them 23 hours a day, so they're going to need 2 sets, so one can be laundered. You can see if they have an extensive total body surface area, they basically can be kind of from head to toe. So this is needed to help with that burn scar regeneration and making sure that the Job's garments loosen the collagen bundles and encourage more of a parallel orientation of the collagen to the skin surface, so it'll decrease the amount of the dermal nodules or that heaping up. The other thing that you can see that these do is it basically promotes venous return. It's just basically like one big Ted hose, and so that is helpful as well, and also protects the healing skin because it's all covered. So while we are using it primarily to loosen the collagen bundles and hopefully promote parallel orientation of the collagen to the skin, we also have some other benefits of that. Again, continuation of the counseling, the body image, and all of that as well. The answer here is D. Flame injury is what we would be expecting. So the nurse is assessing for respiratory injury with anybody with a flame, because if they've had flame, they have likely also had inhalation burn injury as well. The correct answer here is D, as in dog. The correct answer here is B, as in boy, decreasing urine-specific gravity. Basically, when we have an increased urine output, that means that fluid resuscitation is working. When we have an increased urine output, remember that inverse relationship will have a decreased specific gravity. So that's what we wanted to be thinking about in this question. Correct answer here is A. So very important to prevent that cross-contamination. Correct answer here is B. We would be, if we are expecting decreased tissue perfusion, we're going to be seeing that capillary refill that is delayed and potential decreased pulses, absent pulses, so looking for that. Correct answer here is B. We are expecting elevated blood sugar as a normal stress response, as a response to catecholamines being released, but also during stress response, the liver is told to produce more of that stored glucose. So this is just a normal finding at this point. We don't need to do anything about it. The correct answer here is C. We've talked a lot about the tachycardia and the low blood pressure as far as that response, burn shock, hypovolemia, fluid moving from vascular to interstitial, that fluid shifting. So C is the correct answer. So the correct answer here is B. So again, 12 hours after burn injury, no bowel sounds. This is totally expected and normal. We're going to expect decreased peristalsis with any stress response. So we're going to just document this action as the only action. We can definitely expect the possibility of NG placement, anti-ulcer meds started if not done so already. But of our choices here, it is just simply documenting. The correct answer here is C, so it's asking for the priority nursing diagnosis during the first 24 hours, which is that emergent or immediate resuscitative phase. So that's where we're priority is the burn shock and the hypovolemia and decreased tissue perfusion. So C is the correct answer.